terms of assessment of cardiac function, we want to look at the anatomy of the heart. You know, we think of the heart and we think of all these complex components, etc., etc. But the reality is that the heart is, the cardiovascular system is very simple. It's a pump. Actually, what's probably the most complex organ in the body is the liver, followed by the brain, because we have so much unmapped territory there in terms of what section does what and blah, blah, blah. So when we look at cardiac, the thing is that the heart and within, you know, the cardiovascular system is basically a pump. So now in looking at the heart specifically, the heart itself has 3 layers of tissue. It has the epicardium, which is on the outside. It has the myocardium, which is in the middle, and that's the muscle. And the endocardium, which is in the inside. So that the myocardium is where the pump is, and those other 2 layers are basically protecting and working with that tissue. There's 4 chambers in the heart, as you might remember. There's your right heart, which has your right atrium and your right ventricle. Your left heart, which has your left atrium and your left ventricle. And then there's valves that are in between the ventricles and valves that connect the greater vessels to the to the heart. So your atrioventricular valves are your tricuspid on the right side and your mitral valve on the left side. Your semilunar valves are your aortic valve off of the left ventricle, and your pulmonic valve, which is off of the right ventricle into the pulmonary artery. So your pulmonary artery and your right ventricle are joined together by the pulmonic valve, and your left side of the heart would be your left ventricle hooked up to your aorta, and the gate is the aortic valve. You also have your coronary arteries that perfuse the heart muscle itself so that it can pump. You also have your conduction system, which is your stimulation to get the heart to pump. So you need to have the conduction system working in order to stimulate the heart muscle to pump. Simple enough. If you don't have the conduction system, then it's not going to pump. But just because you have the conduction system, it doesn't also mean that the muscle is always going to respond to it. And then you have cardiac hemodynamics that look at how your balancing function in order to get the whole cardiovascular system to work. This next diagram shows a picture of what I just said to you in regards to the heart itself. So deoxygenated blood comes from the vena cava, goes into the right atrium, through the tricuspid valve, into the right ventricle, out through the pulmonic valve, into the pulmonary artery, and then gets down to the point of surrounding the alveolus. Gas exchange occurs. It then it then comes back to the left atrium, the blood oxygenated through the pulmonary veins, goes into the left atrium, goes through the mitral valve, into the left ventricle, and then out through the aortic valve, through the into the aorta, oxygenated to the tissue. And in the lower part of this diagram, you see where you have your epicardium, you have your myocardium and your endocardium. And surrounding the epicardium is your pericardial space. This shows you a diagram of what kind of pressures you would expect in each of these chambers. And that's important because that's going to tell you how well this heart is working, okay? How well this cardiovascular system is working. So on the right side, in the in the vena cava, you're going to find that that's also equivalent to what your CVP is, your central venous pressure. So that's 8 to 10 millimeters of mercury, 8 to 10 millimeters of mercury. And now it moves down into the right atrium, which when you have a catheter known as your pulmonary artery catheter, those pressures start to dissipate. So you see somewhere around 0 to 8. And I also should qualify that by saying that you're looking at spontaneous. In other words, the patient's not intubated, because when somebody is intubated, it's going to make these numbers a little bit higher. Then you're going to go through the tricuspid valve into the right ventricle, and you'll see that there's pressure gradients there. But now you see a systolic and a diastolic, because now this is a bigger chamber, so that you have a systolic and a diastolic. It then goes through the pulmonic valve into the pulmonary artery, and then you'll see higher pressures. Sorry about that. So higher pressures with regards to going into the pulmonary artery, but still within a framework that's similar, that's lower pressures. Remember, your venous system is a low pressure system. That's why it has valves within its vessels. Your arterial system is a high pressure system, so it has no valves within its vascular system for that reason. Now, when the blood comes back and goes back into the left atrium, you've got pressures that are a little bit lower. They're about 4 to 12. But when they get into the left ventricle is the pump of the heart. If your left ventricle is not functioning, then your heart's not functioning. And you can see by this diagram the thickness of the walls of the left ventricle. And that's basically, you're looking at the beginning of your normal blood pressure. And then once it goes up the aorta, you're looking at what your blood pressure is. In terms of the conduction system, I'm sorry, this is a little jumbled here, but the normal conduction system is in terms of looking at the electrophysiology, you have two types of cells within the conduction system. You have those cells that can initiate an impulse, and those are called pacemaker cells. And we'll go over that again when we talk about the EKG. Then you have conductive cells that just simply transmit that conduction. So the pacemaker of the heart in the normal healthy person is the SA node. And the normal impulse distribution is 60 to 100. So that you would expect, that's where you get your normal heart rate from for the adult, 60 to 100. Now, where there's also pacemaker cells is in the AV node. But those pacemaker cells are only reliable for an impulse of 40 to 60. Okay? So now you see, as you go down the conduction system, where you have pacemaker cells that can generate impulses, you're seeing that those impulses are going to start to dissipate, the frequency. All right? Then you're looking at, you go down to the bundle of His, and then you go down into the fibers, and you're looking at a heart rate of about 30 to 40. Sometimes, you see literature says 20 to 40, but, that's a heart rate that you can count on reliable from these, from these pacemaker cells, but they're not really consistent with supporting quality of life. Or I shouldn't even say quality of life, or sustenance of normal function. So which of the following is the primary pacemaker for the myocardium? And the correct answer is sinoatrial node. So now in terms of looking at cardiac action potential, all right? So you need to have an impulse in order for the cardiovascular system to function. You need to have an impulse for the cardiovascular system to function. And there are basically, what you're looking at here is you're looking at depolarization, which is when you have that sodium pump happening, and then repolarization when everything goes back to normal. And there is a refractory period. There is a refractory period whereby cells cannot be interfered with. So they don't have the capability of depolarizing accordingly. So here is what you're looking at. Here is what you're looking at in terms of that whole action potential of the cardiac cycle. And you can see where sodium, potassium are playing a role, and also calcium. It's not showing you magnesium, but magnesium is at the end right here. So in terms of the cardiac cycle, you're looking at each cycle has 3 events. It has rest period, and then it has atrial systole and ventricular systole. All right. So in terms of your ejection fraction, you're looking at the percent of volume that's ejected from the blood, from the left ventricle each beat. And you remember that cardiac output is stroke volume times heart rate. Stroke volume is how much total volume is ejected, and heart rate is your heart rate. So the average adult has a cardiac output of 5. So when you're looking at ejection fraction, you're looking at a percentage. And one of the things that on echocardiogram you'll hear them talk about is what is the ejection fraction? What percentage? And usually, an average person, about 70%, 60 to 70% is what is expected. Once you hit 30%, you have a problem accordingly. So in terms of looking at cardiac output, it's the amount of blood that's ejected with each heartbeat. What impacts that are your 3 components of perfusion. That's preload, which is also known as left ventricular end diastolic pressure, and is really more simply looked at as fluid volume. Afterload is the resistance that the left ventricle pumps against, so that if your blood vessels are constricted, there's more resistance. If your blood vessels are dilated, there's less resistance. And that's an important concept to know in terms of managing blood pressure. If your blood pressure is low, you may want to constrict. If your blood pressure is high, you're going to want to dilate. Okay, so afterload is the resistance that the left ventricle pumps against. And contractility is the strength of the myocardium to pump. And what reflects that is your cardiac output, but more exactly is your cardiac index, because anytime you see the word index, that means it's taking into consideration body surface area. All right, so that your cardiac output for an infant is going to be very different than for an adult, because the body surface area is so greatly different. So that cardiac index, in essence, and even with adults, you can have a small person who's like 5 feet, who weighs 90 pounds or 100 pounds, or you could have like a big, a larger individual who may be like 6'8" and weighs, I don't know, 240 pounds. Their cardiac output to sustain themselves is going to be very different. What you need to be looking at in all situations is these indexed numbers. Influencing factors, with regards to looking at what impacts your cardiac function is obviously your autonomic nervous system, the baroreceptors. That's what helps to control heart rate. We talked about your sympathetic system. We talked that's part of your autonomic, which is part of your nervous system. And your autonomic nervous system, they has the two types of adrenergic receptors: alpha, which deals with vasoconstriction, and then beta. Beta 1, heart; beta 2, lungs. So in this situation, we're talking about the heart. And in terms of looking at what controls stroke volume, or what pumps out, is going to be preload, which is in essence fluid volume. And Frank Starling's law, that's who discovered it, who established the idea of left ventricular end diastolic pressure impacting. So just remember that preload, in most direct term, is fluid volume. And that's reflected by your left ventricular end diastolic pressure, which is also noted by Frank Starling's law. Afterload is affected by your systemic vascular resistance, or the resistance that your left ventricle must pump against. There is also pulmonary vascular resistance. So systemic vascular resistance is your left heart, all right? The left ventricle, what it's pumping against. Your pulmonary vascular resistance is what your right heart is pumping against in terms of vasculature. And both of them are impacted in a sense the same way. Vasoconstriction, more resistance. Vasodilation, less resistance. So contractility is also controlled by your sympathetic nervous system and your catecholamines. Whenever you hear catecholamines, think epinephrine, norepinephrine. And they have both alpha. Well, actually, norepinephrine is primarily alpha, and then epinephrine is alpha and beta. More directly, norepinephrine is actually used in the clinical setting under the name of Levophed, right? So norepinephrine is a pure alpha drug. So norepinephrine is Levophed. It's a pure alpha drug that causes vasoconstriction. All right, and I mentioned to you about neosynephrine is a peripheral constrictor because it basically inactivates histamine, which histamine vasodilates. Increased contractility results in increased stroke volume. So something that's going to increase contractility has what we call a positive inotropic force. When, I don't know, you may have learned about digoxin as a medication. And there are 3 terms that go hand in hand with understanding that drug that you can apply to other medications as well. One of them is inotropic, which has to do with contractility. And contractility can either be positive or negative, meaning it has a good effect, positive, or it takes away from the effect, negative. Then you're also going to look at what they call chronotropy, which has to do with rate, and dromotropy, which has to do with conduction. Okay, so if something is going to assist with contractility, that's going to have a positive inotropic effect. A positive inotropic effect. Now you're going to say, well, why would you ever give something that has a negative effect on contractility? Well, sometimes you would give that in order to bring down somebody's blood pressure. Okay, so that could be the case there. Contractility is obviously going to be decreased by hypoxemia. So you're looking at, less oxygen in the vasculature, less oxygen getting to the heart muscle tissue. So it's not going to work as well. So you need to have that positive, that support given through being able to carry out aerobic respiration. So you're looking at facilitating the function by giving oxygen. Acidosis will decrease contractility primarily because acidosis will also decrease your intrinsic catecholamines. And there's, certain medications like beta blockers that also decrease contractility primarily to decrease the blood pressure. So which of the following best define stroke volume? And the correct answer is A, is the amount of blood ejected with each heartbeat. So for the average adult, it's about 70. So now in terms of looking at cardiovascular assessment, you obviously want to get a health history of the individual. Right now when you're looking at what's happening with this COVID-19, it is affecting your lungs, but subsequently, as with other influenzas, there could also be cardiac involvement as well, and other systems involvement as well. So you're looking at, in terms of, other disease entities that could impact cardiovascular function. You're looking at demographic information. So primarily you're looking at seeing if there's any contributing factors simply from the environment the individual is living in, family and genetic history, cultural and social factors, considering risk factors that are modifiable and non-modifiable. Modifiable, if your BMI is high, you could, lose weight. What's not modifiable is what your genetic history is accordingly. In regards to, common symptoms that patients are going to come with, that you're going to look under, the health history, chest pain is one. Now, if chest pain is one, and you have to remember that when the initial studies were done by the American Heart Association back in the 60s, they did their studies on white males, Caucasian males, European males between the ages of 20 and 40. So that even Caucasian males that were 60, 70, they were not a part of that. Women and minorities or people of color, other cultural backgrounds were not included in the study. So when they talk about chest pain, and they say that chest pain is described as, substernal chest pain, that was common for that particular group. But women, for example, why February is Women's Cardiac Health Month was because they recognized that women were not even addressed at all as well in the study group. So that women, their cardiac pain, they used to say it was atypical. It's not atypical, it's what's typical for women. So it's a more of a referred pain. It's jaw pain, it's pain that goes down and ultimately into the back. So that women don't necessarily present with substernal chest pain. Okay. The person could be complaining of dyspnea, shortness of breath, simply because of the oxygen compromise. If they have right-sided heart failure, they could, be looking at peripheral edema and weight gain accordingly. They could suffer from palpitations related to the heart disease and fatigue, unusual fatigue because of diminished function and diminished reserve. In terms of looking at, past health, family histories, you look at what medications the patient's on, nutrition. Remember, you're looking at cholesterol, fat diet, and subsequently gastric motility with regards to absorption, as we were talking. What's their activity and exercise? Do they have good sleep and rest? What's their, self-perception, self-concept, because that could also lend to activity, exercise, what stress they have in their lives, and self roles and relationships. Physical assessment of your cardiovascular system includes general appearance. So you're looking at, does the person, have visual signs of edema? You're going to look at their skin and their extremities. You're going to look at what their pulse pressure is, which is the difference between their systolic and their diastolic on their blood pressure. Do they have any kind of orthostatic changes? What's their arterial pulses? That also reflects, peripheral vascular disease as well. Do they have jugular vein distension? You're going to, heart inspection, you're going to palpate, auscultate, listen for heart sounds accordingly. And then see what the impact is in terms of the other systems. That's true with any body system. If somebody comes in with a chief complaint, your initial focus is going to be that body system, but then you're going to go back on the head-to-toe assessment. Now, in terms of lab tests that you're going to look at, with regards to people with cardiac issues, you're going to look to symptomatology, you're going to look to EKG changes, but you're also going to look to blood tests. And with regards to blood tests, you're going to look to specific cardiac markers, cardiac biomarkers. You're going to look to blood chemistry, hematology, coagulation, because that's also going to play a role in terms of some of the issues that may be problematic. Is the fact that you have an inappropriate coagulation of blood going on. Now, your lipid profile. Now, stepping back in terms of cardiac disease, and we'll talk about that when we talk about the MI, is that you have to have an understanding of your hematologic functioning, because that, in terms of coagulation, that's the way the body protects the vascular system, and in terms of clotting. So coagulation is the way the body keeps the vascular system intact, okay? So what the body looks for is it looks for smoothness of that vasculature. So if the vasculature is not smooth, then it says a clot needs to be formed. So if that blood vessel ruptures, or there's a puncture from outside, then the clot makes sense. But what also is interpreted as being the fact that the vasculature is not, by that lack of smoothness, is of lipids, the buildup of fats along the blood vessel. So body sees a blood vessel as having fat there, then it says, oh, that blood vessel is no longer intact, and subsequently it needs to, be fixed. So that's when the clotting cascade kicks into play. So the whole purpose of looking at your lipid profile is to make sure that the amount of lipids that you have is not inappropriate and not causing more problems than it's worth. And that's where the statins come into play. You're also going to look at, in terms of B-type natriuretic peptides and C-reactive proteins, as well as homocysteine as well, lending themselves to looking at, is the tissue intact or is it damaged? Electrophysiology-wise, in terms of looking at your EKG to see how well your conductive system is going, your 12-lead EKG reflects only your left ventricle. Now, your left ventricle is the major pump of the heart. If you don't have your left ventricle, you don't have a functioning heart. You could have, I'm not saying that if you don't have your right ventricle, but you could still sustain yourself on some level. So that your 12-lead EKG is only giving you a three-dimensional electrical picture of your left ventricle. So that if something's going wrong with your right ventricle and you want to see it electronically, you would do what they call a 15 to 18 lead EKG. Now, that doesn't mean that the person has two machines on either side, or you have like all of this extra stuff, wires hanging off. You're just going to take your 12 lead precordial leads and move them over to the right side. And that's the deal. Now, in terms of how you're going to monitor EKGs, now you could do it like, with an instance, like you would do with a 12-lead EKG machine, or you could do it with continuous monitoring that's hardwired, which means that my cat's trying to help out with the lecture here. So that when they say hardwire, that means the patient is hooked up to the monitor. All right. So you have monitors there that everybody's hooked up to. All right. Now, that the patient's hooked up to. Telemetry is when you're using the system, oh God, I just lost the word for it. But telemetry is not hardwired. Wavelengths. You're using wavelengths. And interestingly enough, initially when we started to, I can actually tell you this, but when we started to initially use telemetry, one of the things that we found was the systems were going down. And the real reason why the system was going down was because the FDR drive was next to the hospital. And the way that the cabs were communicating in terms of their wavelengths were interfering with the telemetry. So there had to be a different wavelength accordingly established and certain guidelines so that everybody could communicate, get the information that they needed appropriately. Now there's different lead systems in terms of, 3, 5, 12 leads. And then you could also have ambulatory monitoring where somebody could be sent home and you could have a device that picks up what your EKG is over a 7-day period. You also, in terms of looking at cardiac function, could also look at exercise stress tests so that the person is walking on a treadmill, all right? And what's going to be ascertained is what's their EKG, what's their vital signs, and then they want to get your heart rate up to a point. And And there you go. So, you know, one of the problems is that if you're on medication that lowers your heart rate, like beta blockers, getting you to that achievable rate may take a little while. So there you go. Pharmacologic stress testing is they'll give vasodilating agents to mimic exercise. So like somebody who maybe couldn't do that walking, you know, they would give these drugs to. Like one medication is Wotrex or Wotrex. There's also imaging, nuclide imaging of the heart to see myocardial perfusion. They have certain tomography, which is once again radiography, but looking at what they call positron emissions to give another different picture. You know, you're looking at ventricular function that can be seen by an echocardiogram. CT scan can also tell you in terms of, you know, what the shape of the heart is, and magnetic resonance intensity or an MRI can also help visualize with contrast what the vasculature looks like. You know, an echo is echocardiography is ultrasound, and it measures, as I mentioned earlier, your ejection fraction. It can assess the size, shape, and motion of heart structures. It can also, so it can be on top of your chest, or you could do it transthoracic, or you could do it transesophageal. Obviously, you know, you're looking at it closer. So transthoracic would be on top of your chest. Transesophageal is they put a probe down your esophagus and it's closer to the heart, so you get a better picture. Then cardiac catheterization. The first cardiac cath was actually done at Bellevue Hospital. And it was done, I forget, I used to remember the year. It's like the late 50s, early 60s. And what it basically does is it's an invasive procedure, and it helps to visualize basically the blood vessels and structure of the heart. And you can either do this through the right heart, or you can do it through the left heart. And usually through the right heart, you're looking at pulmonary pressures and biopsy of tissue, and the left heart is where they use the contrast to see the coronary vessels. With coronary catheterization, with cardiac catheterization, you have to watch the site for bleed. Now, where they actually put this catheter is generally in one of two places. Well, or one or two. They can put it femorally, or now that you're seeing a lot more of a radial access. So obviously, I think I mentioned this to you earlier when I talked about blood gases. The femoral, you can bleed a lot into the femoral space because of the compartment. Even if you're thin, you can still bleed a lot into that femoral space. So that a better place to access it is the radial. You also want to keep assessing peripheral pulses because you want to make sure that nothing has clotted off. And you're going to look for temperature, color, and capillary refill. Remember, the temperature should be equal and the color should be the same. It should be, in terms of capillary refill, you press on the capillary bed and you should see the color come back in 2 to 3 seconds. You're going to monitor for dysrhythmias because as the actual catheterization is happening, you could be irritating heart muscle. And when you irritate heart muscle, you start to have arrhythmias, okay? And then the person, in order for the vessel to clot and, and not bleed out, is you want to keep the person on bed rest for a couple of hours, all right? And, patient, you're going to monitor them for any signs and symptoms like chest pain or bleeding. And, and then you have to also worry about, with the contrast, that you may cause renal problems. But they actually, give Mucomist prior to the cardiac cath to prevent that nephropathy. And then patient safety. Now with hemodynamic monitoring, you're looking at monitoring a couple of things. And you're looking at central venous pressure. You're looking at pulmonary artery pressure. You're also looking at intra-arterial blood pressure. And then now we have also minimally invasive cardiac output monitoring. And when you're looking at hemodynamics and you're looking at what we've just described, you're looking at those three components of perfusion. The first one being preload, which is fluid volume, as I mentioned, which is also left ventricular end diastolic pressure. Remember Frank Starling's law, right? Contractility, the strength of the muscle. And then afterload is the resistance that left ventricle must pump against. Okay. Now, preload in terms of what's going to measure it. First of all, the catheter that's going to help you measure all of this stuff in an ICU setting is something known as the pulmonary artery catheter. And the pulmonary artery catheter was discovered by developed by two physicians, Dr. Swan and Dr. Gantz, in Cedars-Sinai in the late 60s. And that's a hospital in California. And one of them is still alive. I forget which one, but the one who actually didn't like to lecture is the one that's still alive. And part of that catheter, you're able to monitor something known as the wedge pressure, pulmonary artery wedge pressure or occlusion pressure. And with preload, you can do one of two things. You can either reduce it, get rid of volume, or you can give volume. So in terms of, how you would get rid of volume is you would give diuretics. You would also restrict fluids as examples. Preload enhancement is you would give volume. And then that becomes what kind of volume are you going to give? Are you going to give crystalloids, which is normal saline, ringers, lactated ringers, of that nature? Are you going to give colloids like albumin, or are you going to give blood products accordingly? Now, in terms of contractility, that's your beta-1 adrenergic receptors. And as I mentioned earlier, there's three terms, and I have them listed there. The inotropy deals with contractility, chronotropy with rate, dromotropy with conduction. So what we're concerned with is inotropy. And inotropy is either it's going to help or enhance cardiac output, cardiac index, or it's going to take away. So that in terms of the best number to look at, as I mentioned to you, is your cardiac index. And your cardiac index takes into consideration body surface area, so that, we're not all made the same. So you take that into consideration so that you have a decent number to look at. And normal cardiac index is 2.5 to 4. So that, why you would do contractility reduction would be to decrease somebody's blood pressure. So something that's a beta blocker like Lopressor. There's also a continuous IV medication called labetalol. All right. And then also what you would consider in terms of contractility enhancement would be medications that increase contractility. So digoxin, you may have heard that spoken about in one of your previous classes. It's a very old medication. And the plant's actually, I think, quite pretty that it comes from, but digoxin enhances contractility, so it has a positive of inotropic effect, but it also decreases heart rate, so negative chronotropy, and then it also has negative dromotropy as well, conduction. So whenever you give DIG, you got to check somebody's heart, and there may be certain changes in terms of EKG accordingly. Then in terms of other medications that you might see for contractility enhancement, you may see an older drug, Wotrex or dobutamine, and a newer drug called Primacor. Both of those are continuous IV. And then the last component of perfusion is afterload. And afterload is the resistance that the left ventricle is going to pump against. So that you see the formulas underneath there. I'm not going to hold you to know the formula, but I just want you to be aware of it at this point. So that, first of all, your mean arterial pressure is 1 times your systolic plus 2 times your diastolic divided by 3. Remember that you're in a diastole phase two-thirds of the time, a longer period of time than you are in systole. And your systemic vascular resistance, your SVR, reflects your left-sided resistance, the left ventricle, the resistance that the left ventricle is working against. So the SVR is your mean arterial pressure minus your CVP or your RA, right atrial pressure, divided by your cardiac output. And that alone would be British units, but in this country, we go by, we don't go by that. We go by dynes, and we times it by 80 to get that. So that 800 to 1200 is the normal range. And if that number is below 800, blood vessels are dilating. If the number is above 1200, then you're looking at constriction. All right. So what then is the medications that are going to affect this are those that affect the alpha adrenergic receptors, which cause constriction, okay? Now, an afterload enhancement would be causing vasoconstriction. So we talked about your alpha drugs, and the big alpha drug that you're going to see in the clinical setting is going to be Levophed, norepinephrine, continuous IV. Neosynephrine, phenylephrine is a peripheral constrictor. You will see that used as well, but it's basically only going to work on your peripheral vasculature. Now, the other thing to also consider is that when these medications are administered, there really is no ceiling level on like what's the highest amount you can give. But it's like after you get to a certain point, if you don't really see a change, then you have to change to something else. And that something else could be, you're switching from norepinephrine to neosynephrine or vice versa. And there are certain medications that can augment accordingly. So what you're looking at is vasoconstriction in terms of enhancement. And then you're looking at afterload reduction. So you're looking at vasodilatation and medications that can cause that. And there's some medications like an old medication, Nipride, nitroprusside, that could assist in that as well. So this is just a diagram reinforcing the idea of vasomotor tone and your sympathetic effect in terms of alpha and beta. Now, in terms of hemodynamic compromise, there's two scenarios that you might see hemodynamic compromise. The first one or examples. These are the two most commonly presenting examples. These are not the only examples of hemodynamic compromise, but these are the most common, all right? So sepsis or SIRS, systemic inflammatory response syndrome, and I think you spoke about sepsis in peds. And basically what that is that it's a systemic body response to some type of microbe. So subsequently, you're going to look to facilitating that be corrected, so that your first treatment is going to be correct the problem. But next, you want to see what it's going to do to the patient hemodynamically. So what happens with sepsis and SIRS is you vasodilate. You vasodilate systemically. So if you making a much what you had before. So reflectively, your fluid volume is going to drop. You're going to decrease your preload. You're going to decrease your preload, okay? And because you've dilated, you're going to decrease your afterload. So once you dilate, you're decreasing your afterload, all right? So there's less resistance for the heart to pump against, so the cardiac output is going to go up. So preload, reflectively less fluid volume because of the dilation. Afterload goes down because you vasodilated, less resistance. And now your contractility is going to go up once again because of the less resistance. So treatment is going to be to get rid of the cause. So you're going to get rid of what organism, the appropriate antibiotic, okay? And then you're going to fill up the tank. You're going to fill up the tank with fluids. And in fact, you might remember from sepsis, if once somebody's recognized as having severe sepsis, they give them fluid volume, all right? And they do it according to body weight over the first 30 minutes, normal saline. If that doesn't work, then they consider maybe repeating it or, then going to vasopressors, as I just described to you. Now, with cardiogenic shock, on the other hand, you're looking at your left ventricle just isn't pumping. There's no pump. I shouldn't say there's no pumping. There's a compromise in terms of the ability of that left ventricle to pump. So if it's not pumping well, there could be a decrease in contractility, okay? If it's not pumping well, there's going to be decrease in contractility. Subsequent to that, your body's going to say, gee, I don't have enough volume. I don't have, so one of the body's responses to a decrease in volume is vasoconstriction. So vasoconstriction, you're going to increase the afterload. And then because you've vasoconstricted, you've got a smaller tank. Subsequently, with a smaller tank, you're going to have an increase in preload accordingly. So that treatment for cardiogenic shock is going to be to give diuretics, get rid of fluid, morphine sulfate. The reason you're giving morphine sulfate is to cause vasodilation. And by causing vasodilation, you're making the vascular bed bigger. So more room for that fluid to exist. You're going to give something that's going to enhance that pump, that cardiac output. So that would be positive inotrope, which would be like Witrex and Primacor, as I mentioned earlier. Nitroglycerin can also be given because it venous dilates and it improves coronary perfusion. And then you could actually give a vasodilator like Nipride. And then there's a device called the intra-aortic balloon pump that will also help out with that perfusion. So now, in terms of looking at the pulmonary artery catheter, basically, it's a catheter that is inserted by waveforms. There's the procedure that's followed is that patient needs consent. If you know, because this catheter is not an emergency procedure, it's a procedure of urgency, but not emergency. Okay, so you have a central line bundle. Bundle means that you follow that policy and procedure. You have a timeout to make sure it's the right patient for the right procedure. That you have a pressure monitoring system in place. You're going to insert the catheter by waveforms, and some of the complications that might ensue because you have a catheter going into the heart, as once again, you could irritate the heart muscle and cause arrhythmias. You could push the catheter in too far into the pulmonary artery and cause with obstructing the pulmonary artery. And then anytime you insert something into a patient past their normal protective mechanisms, you're looking at infection. This is a picture of a pressure monitoring system. And with regards to that pressure monitoring system, you're looking at that we really don't use heparin anymore in terms of the flush. We use just plain normal saline because, you know, because of the increased use of heparin, we found that people were showing problems with utilizing it for other reasons. And it was causing, but one of the complications of administration of considerable amounts of heparin is platelet loss. And then you'll see that there's different ports on the catheter that need to be flushed, and then it's hooked up to a monitor. And the important concept for you to remember is that the transducer, which this catheter is hooked up to, converts a mechanical action to a waveform. And that's primarily how you are going to ascertain its placement. So here are some pictures of what a transducer may look like. Here's the catheter on the right. And then what you have here is what they call an introducer. And an introducer, in essence, is placed in order to introduce the catheter and to put the catheter through. These are the different ports in the catheter. The yellow one is generally the distal port, and that empties into the pulmonary artery catheter. The blue port empties into the right atrium, and that's called the proximal port. Then you have your wedge balloon, which is a balloon that blows up into the pulmonary artery so that you can see what the pressures are on the left side of the heart without going into the left side of the heart. And then you can see the thermistor, which is, it helps you to facilitate assessing your cardiac output. So here's another picture of those ports. Now this is the waveforms that you would see once the catheter is being placed. And first, when the catheter is placed into the right atrium, you see what they call an A wave and a V wave. The A wave is when the valve is open. The V wave is when the valve is closed. And both of those little bumps should be the same height. If the V wave is higher than the A wave, then that's showing you valvular incompetency. Then when you go into the right ventricle, you're going to see a systolic and a diastolic. Your systolic, because it's a big chamber. And then once you go into the pulmonary artery, you see a notch here, and that's called the dicrotic notch. And that's telling you the aortic valve is closing. And then when you're looking at the wedge, once again, you're closing off the right side of the heart when the balloon is inflated, and that's only inflated for about 7 seconds, okay? So it's not a long time. It's just to get a picture. And you get to see what's going on the left side of the heart. And once again, you see an A wave and a V wave. When the valve is open, when the valve is closed, and they should both be about the same size. Now, I put in here some pictures of, I don't know if this is going to work right now, but we'll see. No, it's not. But anyway, I put in some movies that reflect what the insertion of the catheter looks like. And then this is just to show you that when you're spontaneously breathing, your pressures are going to be at a lower point and in a different spot than when you're on a ventilator. And this is just talking about cardiac output. Now, I should venture to tell you that advanced catheters, in terms of their utilization, has greatly diminished in time, because now PA catheters are only used in truth when they need to be used. Not, somebody drops their blood pressure, oh, we're going to put Swan in. Line is that somebody spikes the tempo 104 and they got pus in their urine, you don't need a Swan to tell you that they're septic. So that the less invasive procedures that are done, the less likely it is you're going to cause more of a problem than helping the patient. So PA catheters are more routinely seen in a post-operative surgical setting than they are in a medical setting, or even in a CCU. Now, a hemodynamic profile is going to tell you, you're going to look at the 3 components of perfusion. So preload is reflected by the wedge. Contractility is reflected by the cardiac output, cardiac index, and your afterload is your SVR. So those are the 3 components of perfusion. And then you're going to look at blood gases. So you're looking at arterial, which tells you supply, which is more important, or more related to, I shouldn't say more important, but more related to oxygen delivery, respiratory, whereas venous shows you the demand, and that more deals with cardiac status. So you're looking at your venous O2 should be around 35 is normal, and your SVO2 is somewhere around 65 to 75. And if your cardiac output, cardiac index is low, the PVO2 and your SVO2 are low, meaning that the blood's sitting in the periphery too long, okay? And if your cardiac output is, so that would be, those type of numbers would be consistent with somebody in heart failure. So you're not pumping the blood around enough. Whereas if your cardiac output, cardiac index is high, your PVO2 and your SVO2 would also be high. And those V's should be in a lowercase, they shouldn't be in an uppercase. Okay, so these are numbers and values that you're going to see in an ICU setting. And then bringing up the Allen's test again, because of where you're going to be monitoring a blood pressure is through an arterial line. And an arterial line can actually be placed, just like a blood gas can actually be drawn anywhere there's an artery. But the 2 major but never in the carotid, okay, never there. The 2 places where you're going to see an arterial line is going to be in the radial artery as well as the femoral artery. And but the one that you're going to see more commonly is radial, because there's less complications attached to it. Subsequent to that, in terms of the radial artery, you're also going to be looking at where is the dominant hand or the non-dominant hand. That's where this becomes more pronounced in terms of, accessing it. So you want it in the non-dominant hand, but sometimes situations do not allow it. So there you go. But generally speaking, it should be in the non-dominant hand. And the arterial line has, in terms of its waveform, just like the PA catheter, it has a systolic, it has a diastolic, and it has a notch. But in this case, that notch is telling you aortic valve closure. In the pulmonary artery catheter, that notch is telling you pulmonic valve closure. And then I'm not going to go heavy into this, but your central line placement, you have your subclavian approach, which is under your clavicle. All right, then you can figure that one out. And now basically the placement is looked at through ultrasound, through sonography, because, because of the fact that, guesswork. What's also very close up here is the apex of your lungs. So that one of the big complications in years gone by was pneumothorax. So with the help of these visualizing devices, the catheter can be appropriately placed in the subclavian. The other place it can go into is your jugular, your internal jugular. And in essence, there's less chance of complication with that approach as well. And with the central line, also consent is needed. Now, you may see in the clinical area something known as a triple lumen catheter, and that's showing you basically 3 ports, 1, 2, 3, that that are far enough apart so they can be treated as separate line accesses. So by treating it as separate line accesses, you only have 1 stick and you have 3 lines. So if you have to give drips that are not compatible or medications that are not compatible, then this catheter allows you to do that. And there's 2 18 gauge, which is small, and 1 16 gauge, which is bigger. And the distal port is at the tip, so that's where you could also measure CVPs. And this is just showing you the same wave form that you saw with the triple lumen. And that's the A wave, the valve is open, tricuspid. V wave, the valve is closed, and they're pretty close in height. And there you go. And that's it. So we're going to take a 5-minute break, and we'll continue. Okay? All right. Thank you.